Hello. Okay, chalo, let's start. And we have few questions lined up for the NEET Predictor series. Chalo, let's start. The question is like this. Which of the following statement about JME is correct? Juvenile myoclonic epilepsy is correct. JME is usually an autosomal recessive mutation on SCN1A gene on chromosome 2. First of all, is it true or false? My question is this option A true or false? No, there are multiple genes, not only one gene, and there is nothing like autosomal recessive mutation being mentioned there. Myoclonic jerks in JME typically occur while falling asleep at night. No. The characteristic pattern of the myoclonic jerk, is what? More on awakening, not in the night. Carbazepine is a drug of choice because it controls all seizure types seen in JME. No, rather I'm going to avoid that particular drug. So you're left with the EEG, which is showing polyspikes and all, provoked by what? Vortex stimulation, right? So one of the type of epilepsy which is not provoked but rather known as reflex epilepsy is JME. There is to be a difference between reflex and provoked. I'll talk about it later on. So let's try to look into the basic nature of juvenile myoclonic epilepsy. The onset occurs in a bracket of 12 to 18 years of age. Adolescent. The peak is at 15 years and it's slightly more common in female than males. Now, what is the seizure triad that we have? The seizure triad that we have is myoclonic jerks within minutes on awakening, that is pathognomic, followed by GTCS precipitated by sleep loss, that is fatigue and alcohol, and absence seizure. So there are three things that are going to happen. That's the triad that we find. Trigger generally that we find for JME is what? Sleep deprivation, number one. Early morning awakening, getting quite early. Stress, alcohol, and vortex stimulation. And even in females, we have found what? Menses. Right? So vortex stimulation, actually starting a seizure, is a kind of a reflex epilepsy due to a stimulus. Okay. Just for absence seizure, if you remember, there was a stimulus for that as well. That was your hyperventilation. Now it is found to be autosomal dominant with a variable penetrance. And the key genes that we have found is this one. GABRA gene, EFHC gene, and CAC NB4 gene, right? If you remember, the word autosomal dominant is also fine. Now, what do you find on the EEG hallmark of the patient? We are going to see 4 to 6 Hz polyspikes and wave burst. Okay. And most important, photoperoxysomal response. That means on showing photo light and all, it's going to start, right? Background otherwise is normal. Now, this is something important to note, that EEG that you do in absence is normal in the background. Even in patients of JME, we find it to be quite normal. MRI of the brain, that is normal, but it helps me to exclude out structural mimics. Okay, now this is important. MRI in the patient of JME is generally found to be perfectly normal. First line drug that we consider over here is sodium valproate. Why valproate? Because it's a broad spectrum anti-epileptic. It not only controls myoclonus, it controls absence and GTCS also. But the females who are in the childbearing age group, in them we will prefer giving levetiracetam. Lamotrigine is to be avoided in that age group because it may worsen myoclonus, although rare, but it may worsen. Now, narrow spectrum sodium channel blocker that you know, like carbazepine, phenytoin, and oxcarbazepine, they exacerbate myoclonus in absence patient. Okay. Treatment duration, please do remember, it's usually lifelong. Relapse is common when you have a rapid withdrawal of the drug being done. Okay. अरे यार पढ़ाने दो, PDF मिलेगा. As if you are not taking snapshots. अरे सब मिलेगा यार. पढ़ाना बाद में शुरू करता हूँ, पहले पीडीएफ दे दो मुझे, सब ले लूँ मैं। अरे मिलेगा भाई, सबको मिलेगा। Excellent seizure with compliance is the most important thing. Okay. Intellect is preserved. Now, this is something important. Intellectual capacity of the patient, that is IQ, is completely preserved, right? But increased risk of mood and anxiety disorder. Okay. Screen and counsel for that. So, like you go for a stand-up comedy, you enjoy the show, you ask the presenter, क्या सर यूट्यूब पे आएगा क्या, वहां फिर से देख लूंगा मैं? नहीं ना, यू आर पेइंग अटेंशन देयर, सो पे अटेंशन हियर, आई विल गिव यू पीडीएफ। सिंपल है यार। कोई मूवी इफ यू गो एंड सी, डू यू आस्क कि नेटफ्लिक्स पे कब आएगा, मैं फिर से देख लूंगा? अरे ध्यान से देख ले भाई, लिसन टू मी। ओके, so we will listen, we will not write, and it's a just quick recap of everything that we have done in the classroom teaching. So students of DAMS know it, what I'm talking about. Otherwise, if you're not a student, doesn't matter, you will still get an idea what's going on. Okay. So excellent seizure control with compliance. Okay. Intellectual capacity, that is IQ, is well preserved. But in case there is a lot of anxiety and all, please screen and counsel. Now, this is something which I do in my OPD. I know many girls have come and told me, right, that sir, I'm taking valproic acid since my adolescence, and I am a known case of juvenile myoclonic epilepsy. I'm not yet married, but later on the changeover we can think about. Okay. Now, valproate is something, please remember, can control it very well. No doubt on this, is a broad spectrum. But in spite of valproate therapy, I found a female in my OPD who has come with recurrent myoclonus. The typical format of JME, she could come with that. So what should we tell the patient? Add a new anti-epileptic. What should I tell the patient? Add a new anti-epileptic, or maybe increase the dose of valproic acid. Now the ball is in your court. That's why I discussed this topic separately. So very, very common. Someone said Samir Raina joined the chat. नहीं भाई, मैं घर पे ठीक हूँ, जेल नहीं जाना. Comedies are under threat nowadays. No joke in the class. Don't send emojis. Okay, let's stick on the concept. Batao, there are two options. Patient of valproic acid therapy has come with recurrent myoclonus. Now add increased dose. This is what everyone does. So no, listen to me peacefully. First of all, your thing should be reassess the patient. Okay, why reassess? Yeah, why reassess? Because in case the patient is suffering with sleep deprivation, or even a simple thing known as anxiety, then what should I do? Tell me. Adding a new anti-epileptic drug, increasing the dose of toxic valproate? No, nothing. Just add what? An anxiolytic in night time, HS. Why? Because if the patient gets a good sleep, the provoking factor for this thing is basically taken care of. Okay. Yeah, that's what epileptic patients, when they come to our OPD, I always tell them one thing. Take bhai, don't watch your mobile phone too long. I've seen this reflex epilepsy. I've seen this in the metro once. If you watch a mobile phone too long, especially the YouTube videos, they are too quite glary. That kind of a photic stimulation generally precipitates the entire episode of JME again and again. Yes. So always rule out triggers. One thing. And also tell the patient to avoid what? Photic stimulation. There is a difference between a term known as reflex epilepsy and a term known as provoked seizure. So my handwriting is very bad. Sorry for that. Not my handwriting, it's my font actually. Doesn't matter. Dr. Srinath will improve it and find better. So anyway, reflex epilepsy versus provoked seizure. There are a lot of differences. Like if a patient sees a light and gets a seizure, vortex stimulation, that is reflex epilepsy. If the patient has got fatigue, decrease in sleep, yes, that is reflex epilepsy. But in case the patient is having fever, patient is having hyponatremia and then seizure, or maybe alcohol withdrawal seizure. Look at the beauty of alcohol. Taking alcohol gives you content in life, but withdrawing alcohol removes your make you discontent, and that discontent converts into a seizure, provoked seizure. So know these facts. I've long back recorded a reel on Instagram on my Insta channel, Neurologically Yours. You can just go and see those reels over there. I've tried to basically try to differ out what is the difference between reflex epilepsy and provoked seizure. Okay. Right. Chalo, so we're done with Jamie, and one thing that I think so even the Demsonians would have learned today from me, that there is one provoking factor apart from sleep deprivation and anxiety to precipitate myoclonus, or even Jamie. Okay. So that is what? Yeah. Good question. Sir, what is the term that hyperventilation in absence? Is it reflex? Yes. Hyperventilation. So very often in your OPDs, you might see this written by a neurologist only. Say, I'm not a neurologist, I'm a pseudo-neurologist. I always tell the student, I have not done DM, but I'm a pseudo-neurologist, but I know neurology at least. So we often write in our OPDs reflex epilepsy because there is something which is precipitating at that particular moment. Sleep deprivation, vortex stimulation, hyperventilation. Okay. Provoked seizure is an entire different thing. You can just go through the reels. I've told everything about it there. So what did we learn from this? That apart from the fatigue and maybe sleep deprivation, one more important trigger for this is your vortex stimulation, and something extra. It's polygenic in nature, one thing clear, but the penetrance or maybe the pattern, okay, is autosomal dominant, right? Yeah, I'm big fan of Dr. Srinath's handwriting. We are launching his own font in Microsoft Word, Srinatham, with 28% GST from Thai. Sorry, no jokes. All going live. Hello. 66-year-old male with a long-standing type 2 diabetes suddenly develops violent amplitude flinging movement of the left arm and the leg that worsens when he tries to sit up and disappears during sleep. The question would have answered, but I made it pretty easy. That MRI is showing me a lesion in the right subthalamic nucleus. So what movement disorder is it? Yes. The movement disorder that we find over here is hemibelesmus. This has come in the exam somewhere like this in INI and NEET, both the papers. Okay. So quick recap of, thinking about all the movement disorders, and maybe a kind of a go-to treatment in which you give the treatment and the patient gets better in the OPD itself. Chalo, ethetosis. What kind of movement style is it? It's a slow writhing movement of the digits like this. Yeah, okay, nahi. Where is the lesion sitting? It is sitting in the striatum. This is what is given somewhere in Harrison also. But the exact site for this is globus pallidus. The exact site is globus pallidus because there has been a query on this also. The striatum is written in Harrison. I think chalega. But the exact site, the part of the striatum where you find it is globus pallidus. And what is the signature etiology? Now this is important. Okay. Signature etiology is kernicterus. Yeah. This is again given in pediatric textbook. And the treatment for this is tetrabenazine. Yeah. Again in the higher books they give the treatment for this is tetrabenazine. Chorea is brief dancing flicks. Yeah. Dreams prancing flicks like this. Sitting like this. I'm doing like this. and the lesion is somewhere seen in the caudate nucleus. Signature etiology can be Huntington or synonyms. Okay. And again, a very old question: what is the treatment maybe of choice for this? Tetrabenazine. Great. Hemibellismus is a unilateral violent flinging movement that you saw. The lesion is somewhere in subthalamic nucleus. What is the etiology for hemibellismus? Now, as mentioned in the question earlier, it is latent stroke. Small infarcts can cause it in the subthalamic nucleus. And the treatment is dopamine blockers. Dopaminergic antagonists are generally given plus minus DBS, deep brain stimulation. Then don't forget your dystonia. There is sustained twisting posture of the limb. The limb is moving towards something which is very, very slowly. There is some problem in the circuitry of the direct indirect pathway, especially in the GPI part, globus pallidus interna. The cause for this is focal idiopathic or even drugs. There are a lot of treatments for dystonia like muscle relaxants and all, but maybe one treatment which we nowadays prefer doing is botulism toxin, although results are plus minus variable for everything, maybe every patient. Okay, so that's a quick recap of all the movement disorder that we know. One is ethitosis, one is chorea, other one is hemibellismus, and the last, don't forget, is dystonia. Right, so easy question, simple answer. Now let's go to Mr. DLB by Lewy body. Which of the following statement about DLB is true or correct? Early predominance of short-term memory loss with minimal hallucination characteristic of clinical presentation of DLB. No, not minimal hallucination, it's major. In Parkinson's disease dementia, Parkinson motor signs begin after dementia by at least 1 year, distinguishing from DLB. Ulta hai. Remember, in Parkinson, all the motor symptoms will happen first and then the memory loss will come in. Haloperidol is a standard antipsychotic doses preferred to control visual hallucination in DLB. No, I'll talk about this also. It's a double-edged sword. Using haloperidol and evil levodopa. This is a different story. What are we left with? Something that I don't know. Sang mala jo mala maite nahi. ऐसा होता है देखो. You go for the exam and you don't know the answers. चलेगा यार. Read the options, rule them out, you'll find the correct answer. Even if you don't know the answer, now you know the answer. Rule out therapy. Be smart in the exam. So let's understand. I agree on this that dementia of Lewy body is being ranked after Alzheimer or not. This is keeps on fluctuating. Psychiatry people say no, it's come before Alzheimer. But in the neurodegenerative textbooks that we read, we find that still they keep Alzheimer on the top and then the DLB comes. Okay. What do you find inside the brain? Alpha-synuclein Lewy body and neurites are seen. Okay. Now these degenerative particles or the cells that you find, sometimes you might confuse it with Alzheimer also. But what is pathognomic over here is not tau protein, it is alpha-synuclein Lewy bodies. And this is the core clinical feature given in our higher books. What are the heart tetrad, hallucinations? They are well-formed hallucination, they are vivid of the people and animal. Like it's a well-formed hallucination. You'll see the entire person coming in front of them. The complete face. Yeah. Alternating cognition in alertness and attention. And that also fluctuating. REM sleep behavioral pattern. Yes, they will enact the dream. Yes. So this is something important. Like, when you are sleeping, your body is flaccid. You don't enact the dream. But the body is rigid also, no? So he will try enacting the dream in front of other people. Like, he'll be fighting with people, giving money, lo, paisa lo. All these things. You giving exam, enacting dream. But suddenly you realize your exam got postponed. No, it's not postponed, it's on time. Don't worry, it will not get postponed. I hope. Fingers crossed. Last time what happened, NEET PG? Yeah. Your exam preparation did not flop, but your Goa preparation flopped. I remember. So many students were angry. Mera Goa ka ticket. Okay. Parkinsonism. Symmetrical bradycardia and rigidity and less of tremor. Now, this is something important. Most of the patients whom I attend with Parkinsonism plus or atypical, are symmetrical. Now, Parkinson disease is a asymmetrical disorder, unilateral presentation. But in Parkinsonism plus, like PSP, DLB, everyone, the entire story is more of what? Symmetrical. And tremors, very important. Tremors are the first classical feature of Parkinson. Yeah. Tremor is going to be less predominant over here. Now, this is 2017 consensus, probable DAB and possible DLB. So, if two core features are seen, it's enough to call it as a patient of dementia of Lewy body, or maybe one indicative biomarker. Okay, now, what are the biomarkers? The biomarker that we find is decreased dopamine transport uptake in SPECT. See, it's all dopamine depletion. So obviously transport of dopamine will be less because there is less dopamine. And maybe decrease cardiac MIGVG sympathetic uptake. Now this is something important. In the cardiac tissue, MIBG sympathetic uptake will also be less. Polysomnography could be seen. REM sleep disorder without atonia. Now this is important. Hypertonia is seen because of rigidity in these patients, not atonia. Okay. So if you read in somewhere radiology about this in detail, you will find that the SPECT and the PET will show you occipital hypometabolism. It is known as a cingulate island sign in patients of DLB. So occipital lobe visual hallucination, yes, right? So there's something going wrong there. So you can connect. And most important in the MRI, there is relative hippocampal sparing. Was marked hippocampal atrophy in Alzheimer. Alzheimer has got a major hippocampal atrophy. Okay, here there is most of the relative hippocampal sparing. Now, what are the red flag signs? Please remember. Severe sensitivity to antipsychotics. Now, this is important. The moment I give an antipsychotic like haloperidol, their rigidity will increase. Yeah, because it's all due to decrease in the dopamine effect or maybe the level. Autonomic failure. Now, it quite mix up with MSA variety of Parkinsonism plus, and early autonomic failures can also happen here. Now, this is something red flag sign. Red flag in the sense that if they develop, you reconsider your diagnosis one, like MSA. So if you have an early autonomic failure, then think about MSA. And don't use typical antipsychotic ever in them, because it is going to worsen the rigidity phenomena. Because if a patient comes with visual hallucination, that's it. Then I think, I know he's psychotic, I will give antipsychotic typical, and that will worsen out the whole movement disorder spectrum in the patient. So what are we going to give the patient as far as the treatment part is concerned? In case the patient has a cognitive defect and a hallucination problem, rivastigmine and donepezil will help. Basically, to some extent we find that the cognition or dementia part responds very well to these two drugs. And what about Parkinsonism? Please remember, you have to give them low dose levodopa. This I was waiting to explain again. So because in them, if I give levodopa, that may worsen what? Hallucinations. So look at the story here. At the moment I give levodopa, it worsens the hallucination. The moment I give haloperidol, it actually increases the Parkinsonism. What about the REM sleep behavioral disorder? Melatonin is a good advice for the patient. Okay. And as far as possible for treating agitation and psychosis in them, avoid haloperidol. We need to give quantipine and clozapine to the patient. And please remember, as compared to Alzheimer's disease, another brother of this family, neurodegenerative, okay, the mean survival is just 5 to 8 years. That means they have a faster decline as far as the prognosis part is concerned. Nothing new here, just a repeat of this, like, early autonomic features, unexplained fall and syncope. Red flag clues. Why red flag clues? That I have started my patient on thinking that it's dementia, Lewy body, and suddenly autonomic feature happen. That goes in favor of what? Multiple system atrophy. If I'm not wrong, I've taught you in the classroom also somewhere that, there is a wheelchair sign of Quinn. There's a wheelchair sign of Quinn that we find. And that is seen in patients of Parkinson disease specifically. Now, what is this wheelchair sign of Quinn? I gave my patient a Parkinson disease, a therapy levodopa. And I found the patient who was walking with a fascinating gait in the last OPD. Fascinating gait in the last OPD. Today has come on what? Wheelchair. What does this mean? This means the utter failure of levodopa. That means the brain receptors are not responding to levodopa. They are not there only. How will they respond? Please remember, this is something which is not a Parkinson disease patient. It is a patient of Parkinsonism plus, atypical. Any patient who doesn't respond to your levodopa therapy, think about Parkinsonism plus or atypical Parkinson every time. The wheelchair sign of Quinn. If a patient, tell me the answers now. I want your participation here. If I give a patient who is having Parkinson-like symptom and I give my patient what? Levodopa, and visual hallucination increase, what is my diagnosis in mind? What do I keep in mind then? I keep in mind what? Dementia of Lewy body. Okay. Right. So the early exam tip that you can know over here is the patient should have an early visual hallucination with a Parkinsonism symptom, and dopamine uptake, effect loss is seen. Okay. And please remember, if a patient of Parkinson disease has more motor symptom and the dementia comes before maybe 1 year, so the benchmark is 1 year. If the dementia comes 1 year prior, after the onset of Parkinson, if it comes 1 year before, early it comes, then you think about what? Dementia of Lewy body. If it comes after 1 year, you think about what? Yes, you think about Parkinson disease. So I'll just summarize this again. DLB versus Parkinson disease. Parkinson disease is what? Asymmetrical. Dementia of Lewy body has a symptom which is more symmetrical. In a patient of Parkinson disease, you have tremor, you have rigidity, and of course akinesia. While in DLB, the story is different. You have rigidity and then the tremors. And most important, memory loss, dementia that I know. In DLB, after the onset, if I'm thinking, should be less than 1. If it is more than 1, it is a case of Parkinson disease. Got it? And at the end, visual hallucinations. Visual hallucinations. Visual hallucinations are seen in DLB. They are not seen in patients of Parkinson. Okay? How you remember? And this is something which is very frequently asked in NEET, INI, everywhere. Dementia of Lewy body. So comes another question. Don't neglect this topic. 65-year-old right-handed male presents with stroke symptoms. On examination, he ignores the object on the left side, shaves the right side of the face, eats the food only on the right side of the plate. The lesion is located where? Tell me. Someone is asking again the same old doubt. Single shift hoga kya, sir? I'll tell you, 2014 or some that year, 15. The NEET PG used to be like Navratra. Not Navratra, Ramzan also something long. And the exam used to float for 10 to 14 days. Go and ask your seniors. At that time, there were so many slots. And there were so funny slots, like one paper never had anesthesia, second paper has a lot of anesthesia. So purana time to aur kharab tha. Okay. Chalo, let's find the answer. Yes, you know it correctly. It's a right parietal lobe. Now, what is this symptom? Hemispatial neglect. This happens due to lesion where? In the right non-dominant parietal lobe. The patient neglects the left side. It's a right MCA territory infarct. Okay. Now, what is that? Artery. Tell me the artery. It is an inferior division of the middle cerebral artery on the right side, which will involve a structure, angular gyrus, located in the inferior parietal lobe, which is going to create this symptom of hemispatial neglect. Okay. And don't forget, patient ignores everything often on the left, dressing and grooming only on one side. Okay. And the patient denies the deficit, anosognosia. How do you find it? Clock drawing. Now this is a common confusion which comes in every student mind कि sir आपने जो clock दिखाया in the exam it comes different. So there are two methods. One is object copying, or maybe in a sense you ask the patient to put all the numbers. So I have drawn the circle myself first of all and ask him to put all the numbers. So when he wants to put all the numbers, he will put it on this side because for him the clock exists only on the right, doesn't happen to be seen on the left. Line bisection test. You bisect the line like this, normal. This patient of mine is going to bisect the line like this because he ignores everything on the left side of the line. Cancellation test. There's a big paper over here. I ask him to cancel the A's on the paper. He'll cancel the A's only on the right side of the paper, not the left side, because he neglects everything on the left side of the page. So there are a lot of tests that we can think about in which the person will be able to complete the whole task on the left side. Okay. Okay. This one. 62-year-old male presents with sudden onset right-sided weakness and facial drop. Neurological examination shows right upper limb more weak than the lower limb. Right lower facial palsy. Right lower means UMN facial palsy. An expressive aphasia. Which artery of MC is involved? How do you get the answer? Expressive, cannot talk properly. It's a patient of Broca's aphasia. Yes. If the Broca's area is involved, frontal lobe is involved. And we already know if aphasia is a symptom, the lesion has to be on the left side. And if the frontal lobe is involved, which artery is involved? Which part of the MC is involved? The superior division. Right. Okay. So I don't think so need to discuss everything, but just a quick recap of everything, baby. If you have a lesion in the superior division, left and the right hemisphere, what will happen? Motor deficit will happen in both of them. Sensory deficit again will happen in both. But please remember, if the lesion is on the left, Broca's area will be involved, expressive aphasia will occur. Okay. But if the lesion is on the right, then hemispatial neglect will occur. Right. Eye deviation. Now this is important. Eye deviation. Always towards the lesion. Always towards the lesion. Always towards the lesion. And just make this correction. This is regarding the inferior division. Right-sided inferior division, hemispatial neglect will occur. So eye deviation, please remember, it's always towards the lesion. What is this? Inferior division of MC if it is involved. On the left side, right superior chordinopia will happen. And now this superior chordinopia means which part of the brain is actually involved. It's more likely to be which involvement, temporal or parietal? Please tell me. So not only chordinopia, in the patient will find what? Heminopia. Because of visual radiation, not only parietal, temporal is also involved. Heminopia. Heminopia. Gershman syndrome when the lesion is on the left. Neglect anosognosia, hemi-neglect when the lesion is on the right, inferior division. Okay. Aphasia will happen when the lesion is Wernicke's on the left, and no aphasia when the lesion is on the right side. Okay. And what about MCA territory stroke, which is lentico-striate division? Pure motor hemiparesis, internal capsule is also known as what? Tense hemiparesis. And no cortical signs happen, no sensory loss, nothing happen. then the lesion is in the MCA lenticular branches. So aphasia is something which happens in the left-sided lesion. It's not seen in the right-sided lesion. Neglect happens when the lesion is in the right side. But what neglect? Neglect of the left hemispatial space. Apraxia, please remember. Now this is something important. Ideomotor apraxia possibly happens when the lesion is on the left, dominant parietal. On the right-sided lesion, less common. So there's another difference now coming. Apraxia is more often seen when the lesion is on the left, dominant parietal zone. On the right side, if there is a lesion, no, apraxia will unlikely to happen. Now, which apraxia I'm talking about? I'm not talking about your construction apraxia and all that. No. I'm just talking about ideomotor apraxia. See, depends on the involvement of the particular area. In case the temporal is involved, because inferior division supplies the temporal, you will have superior chordinopia. But in case the parietal wala is also involved, then you will have inferior both. So it can be chordinopia also, it can be heminopia also, right? Okay. So quick recap. Superior division, what is the major problem? Motor weakness, less than language. Inferior division, what is a major problem? Sensory problem is more, okay, and visual problem is more. Left MCA territory infarct or anything, aphasia will happen, right? What will happen? Neglect will happen. And always remember, eye deviation in an infarct or a destructive lesion is always towards the lesion, okay? And hemiparesis is contralateral, okay? So in frontal eye field lesion, when MCA territory is involved, then the eyeball is going to move towards the lesion. So if this side is a lesion, the weakness will come on that side, but the eyeballs are going to move towards the lesion. In case you have only motor loss without cortical sign, then means it's a deep MCA infarct in the internal capsule. Chalo. 58-year-old right-handed male presents with stroke symptom. He speaks in short, effortful phrases, has difficulty in completing the sentences. Comprehension is relatively preserved. Repetition is impaired. Which of the following type of aphasia are likely to be seen? Effortful phrases, difficulty in forming complete sentences. Word formation is at fault. What kind of aphasia is it? Expressive aphasia. Comprehension is preserved, Wernicke's is fine, repetition is impaired because Broca's is not working. So what aphasia is it? Broca's aphasia. So I'll give you a quick recap of them as well, but intentionally in this table I've removed out naming, because naming का क्या चक्कर है ना, it's somewhere specific for anomic aphasia. So चलो one by one we'll see. In Broca's or expressive aphasia, fluency is lost, comprehension is intact. Repetition is lost because he cannot form the word. It is also referred as a non-fluent aphasia, effortful aphasia, and the patient is aware of the deficit. Wernicke's aphasia is receptive. Fluency is intact, comprehension is gone, repetition is lost. Fluentless but meaningless speech. And again, he is unaware of the problem because he doesn't understand the problem. The one who is aware of the deficit is Broca's. One who is unaware of the deficit is Wernicke's. What is global? Everything is gone is global. Simple. What is conduction? Arcuate fibers are lost. The connection that happens between Wernicke's and Broca's is lost. So individual fluency and comprehension is intact, but repetition is lost. What are transcortical aphasias? Transcortical motor is like Broca's with preserved repetition. Transcortical sensory is like Wernicke's with preserved repetition. And finally, what is this? Anomic, where the patient has a word finding difficulty. Cannot name. Sab kuch theek, only naming is gone. Like in my house, my wife keeps on telling me. I hope she's not listening to this live YouTube session. Arey wo de do. Moment I say kya? He has a word finding difficulty. Arey wo leke jao, wo karo. Kya? अरे झाड़ू लेके आओ, लगाओ. Word finding difficulty. Okay. But After many years of marriage, I don't know how many years. I'm accustomed to it. I have those words in mind. Track to chal. I can crack jokes on wife, no problem. Not on government. Safe. 72-year-old male presents with acute left-sided hemiplegia, aphasia, has 3 hours ago. My wife has Rohit Sharma syndrome. Blood pressure is 175 and 95. NCCT of the brain shows no hemorrhage. Platelet is 90,000. INR is 1.2. Glucose is 130. Creatinine is 1.5. No prior stroke surgery. Which of the following is the most appropriate next step? Look at the catch in the question. Defer thrombolysis due to low platelet count. Okay. So low platelet count is a contraindication to do what? Thrombolysis. So what is the concept of window period? I hope you know. For an IV altiplase that is recombinant TPA, you can give it within 4.5 hours of onset. Got it? But for mechanical thrombectomy, conditions apply. You can take it up till 24 hours. Recombinant TPA altiplase, the dose is 0.9 mg per kg. Maximum dose is 90 mg. 10% bolus within 1 minute. And 90% of it has to go slowly over 1 hour. They have asked this also. NEET PG people. Clinical diagnosis, what are the inclusion criteria? Very simple. No hemorrhage on a CT MRI, age above 18, and onset of symptom within 4.5 hours. I'm talking about the IV format. What are the absolute contraindication? Intracranial hemorrhage on imaging, platelet count less than 1 lakh, INR more than 1.7, or prothrombin time more than 15 seconds. And please remember, systolic BP above 185, diastolic above 110, uncontrolled. Recent major surgery within 14 days, 2 weeks. Intracranial hypertension, AVM or aneurysm already there. Any active known bleeding disorder, that is bleeding diastasis. Relative contraindication. This has come in the articles more often, like, seizure at onset is a relative contraindication because there is some cerebral edema there. Don't try to thrombolize those patients. They will bleed because of edema inside the brain. Recent GI and a urinary bleed in 21 days. Pregnancy. There are not many studies done. Post-MI pericarditis, if it is there and the patient suffered with stroke, please don't thrombolize because you will have a bleed in that area of pericarditis and a tamponade. Okay, that was a relative contraindication. So please remember, essential investigation before thrombolysis. What you are going to do? Non-contrast CT scan of the brain. Please exclude out hypoglycemia because it mimics stroke very often. And most important, CBC, PT-INR, APTT and creatinine. Creatinine if needed. Prothrombin and platelet count in the CBC has to be looked. What is post-thrombolytic management monitoring? No antiplatelet anticoagulant for 24 hours. Repeat CT scan after 24 hours to look for any leak inside. Monitor BP, neurological status and signs of bleeding. Now someone was asking me a lot, sir, ye kya hai? I'll give you an idea on this. There are scales that we use and maybe the scores that we use clinically as well as radiologically to basically look at a patient who will benefit from a mechanical thrombectomy. So there is an extended window beyond 6 to 24 hours, mechanical thrombectomy in a large vessel occlusion. Although clinically we say that within 6 hours of onset, if you give a intraarterial, that is, you give the drug into the artery, mechanical thrombectomy, patient will benefit. But 6 to 24 hours, that window now. If the patient has M1 occlusion or internal carotid artery occlusion, what is M1? Look at MCA. This is M1, this is M2. The M1 occlusion is a large vessel occlusion, or even the internal carotid has been involved this time. The mother of MCA is ICA. Any one of them involved is a large vessel. But in case the patient has an NIHS score more than 6, aspect score more than 6, or a perfusion mismatch on a CT and MRI. Okay, this is something in the journal articles we often mention perfusion mismatch. That is, there is some ischemia still going on in the brain. Then you go for a large vessel, maybe mechanical thrombectomy. Chalo, look at this question. 49-year-old female patient with aneurysmal subarachnoid hemorrhage was managed conservatively. On day 6 of admission, she developed new onset right-sided hemiparesis dysphasia. CT scan shows me no new bleed or hydrocephalus. What is a likely cause for a current neurological deficit? Obviously, vasospasm due to cerebral ischemia. But who is causing that vasospasm? Collected blood around the vessel in the subarachnoid space, and that vessel is supplying the brain. So let's quickly revise subarachnoid hemorrhage. Easy, important topic. What are the causes of non-traumatic spontaneous SAH? Berry-aneurysm rupture. The most common cause of non-traumatic SAH is berry-aneurysm rupture. Otherwise, more of the time that we find it is traumatic. Most common cause of SAH is traumatic SAH after head injury. The rare ones that we have is neoplasm related bleeding in the subarachnoid space or even coagulopathies. But that's the rare one. Apart from this, don't forget the AV malformations and some mycotic aneurysms found in the blood vessels. At least you should remember the most common cause of SAH and the most common cause of spontaneous or non-traumatic SAH. Now going on to the common sites of aneurysm. What is the overall most common site? ACOM. Anterior communicating and ACA junction, that part. And one thing which I will write over here, if you have an ACOM aneurysm or maybe at the junction, like if this is the two AC and the ACOM comes between them, someone who sits over here, I hope you know, is the optic chiasma. In case the optic chiasma is getting compressed from below, you can have a visual field effect like a pituitary tumor has got. What? Bitemporal heminopia. PCOM aneurysm. Please remember there is a third cranial nerve palsy which happens. Hemiparesis happens when there is an MC aneurysm. Someone asked me, sir, that question that you are discussing. Isme the patient had some aneurysm rupture, you treated or not, managed conservatively. Now this patient has come with this problem, hemiparesis. Now where is the aneurysm, sir? Is it at the most common site, ACOM, ACA? No. Look at the concept. If you have an MCA bifurcation aneurysm, the MCA bifurcates at the sylvian fissure. And if the blood collects where? In the sylvian fissure, it will come and compress the artery from outside. So looking at the deficit also, I can tell you like where is the problem likely to be. Okay. So in this question and this case also, you found a delayed deficit, aphasia, hemiparesis, MCA. But sir, in case sir, the aneurysm is at the vertebro-basilar junction, I hope you know, two vertebral joint to become basilar. Or maybe the basilar bifurcates to become PCA. Then what symptoms are going to come? As a delayed deficit which happens later on. Simple, na? If you remember this posterior circulation of the brain, it supplies your brainstem. So if you have the aneurysm in the posterior circulation, then in that case the patient will have what? Some signs. So they might ask you a question like, see, they've already asked about bitemporal heminopia, ACOM aneurysm. This is a very favorite question of NEET PG. They might come and ask you, now the patient had SAH, now has developed hemiparesis, now tell me where is the aneurysm. So you should track it down like this. The patient had SAH, now he's having brainstem symptoms. Where is the aneurysm? On the basilar tip, on the back side. Over here maybe. Okay. What are the acute presentation of SAH? Thunderclap headache, neck stiffness, nausea, vomiting, LOC, seizure early. Seizure is rare actually. Early seizure happens. I've seen this, but it's rare. Focal deficit. Yes, this is something as an acute presentation I'm talking about. Because this aneurysm, you know, pecom aneurysm. If you remember this artery, this is the parent artery ICA. It bifurcates into AC and MCA. Got it? And this is the pecom coming from behind, the posterior communicating. And if you have the aneurysm over here, somewhere nearby the third cranial nerve is moving around. So I'm writing this as an early symptom, maybe a prodromal symptom. Before actual rupture of aneurysm happens, there could be compression of a third cranial nerve. But look at the third nerve. This is something important now. In the third nerve palsy that you have, please tell me an answer for this. The pupillary fibers in third nerve palsy due to pecom aneurysm are going to get involved early or late. If you have attended the lectures, you know it. It's a very simple guess. सांग मला जो मला माहिती नाही. Adri, I know both the languages, Kannada, Marathi. Safe in both the states. Late. Ash. Late. Okay. I'll clarify this concept. This is the third kidney nerve I've cut in a transverse section. The outside fibers are peripheral fibers. They are your pupillary fibers. Outside fibers. So I'll just shorten the arrow so that you don't get confused. Correct? And the beachwala fibers are your oculomotor fibers. How to remember? Third nerve, peripheral fibers are pupillary and the center one are oculomotor. In case I have the aneurysm over here, correct? What it will catch first? Common sense, yaar. It will catch the pupillary fibers early. Why late? Ulta dekho. In case you have a diabetic problem, third nerve palsy, what happens in diabetes? There is a vasa vasorum, a small vessel that supplies a cranial nerve. It suddenly got blocked in the middle. So there we have what? Just the ulta, pupillary sparing. Because pupillary fibers on the periphery, they can get the blood from outside also. But the central oculomotor fibers are just surviving on the central artery, and that artery is getting blocked. Okay. Now delayed deficit is a major exam question. Vasospasm happens within 3 to 14 days, lead on to delayed cerebral ischemia. Diagnosed by what? Transcranial Doppler. Nimodipine is a drug that you can give to the patient. Hydrocephalus occurs, rebleeding occurs, and it is the most common cause of death that we see in the patient. And hyponatremia occurs due to SIDH or cerebral salt wasting. Yes. In the classroom, I always teach cerebral salt wasting, but in SIDH also happens. Given in Harrison, both the things can coexist. Okay. Investigation. Yes. As per Harrison, it has got a high sensitivity in the first 6 to 12 hours. CT scan. Lumbar puncture. Yeah. If the CT is normal and suspicion persists. Still given in Harrison, but in a practical sense, we don't go and do this. Because in a high raised ICT, if I do an LP, it will cause coning and death of the patient. And mind you, this has also come long back. It was a very favorite question of my era. You know, when the exam used to happen on time. And the exam used to happen on time. 6th of January, first week, first Sunday, second Sunday of January. Times used to be free by this. We used to join PG. Purane din, achhe din. When achhe din was there, yes, this question was this very favorite. You know, xanthochromia, when does it come? It comes after 12 hours. Doesn't happen initially. CT angiography and DSA is for what? Aneurysmal localization. MRI will show you late subarachnoid. So if you have missed on a CT, don't go do LP, do MRI. See that. So the late SCH, the old SCH can be found on a MRI. What is the treatment approach? Target BP. Keep on teaching this everywhere nowadays. Is to keep the BP below 160 before clipping and coiling. Okay. What is the treatment? Surgical clipping, endovascular coiling. Vasospasm, what are you going to give? Nimodipine. And for hydrocephalus, you can put an external ventricular drain or a VP shunt to the patient. Okay. So don't forget the high yield points for NEET PG. ACOM is the most common site for the aneurysm. ACOM aneurysm will cause third nerve palsy with early pupillary involvement, and बाद में ptosis is going to come. Vasospasm is a most common delayed complication, often prevented by what? Nimodipine. Real bleeding is an often cause of sudden death and early death in the patient. Triple H, I agree. I have intentionally not written this because it's still debatable. For teaching ठीक है, but what is exact, I'm telling you that. Xanthochromia now. This is again textbook line, is gold standard. अरे बाप रे क्या बात कर रहे हैं? हाँ. So old questions, we used to get these questions, when CT scans were not available, the old question bank had this. And it's still written in the book. If the CT is negative, go for LP, but nowadays 64 slice CT will find, everything easily. Coiling and clipping, mentioned both of them. See, it all depends case to case. What was a recall by a student? So there was a question given to me, sir. So this is a wide neck aneurysm and this is a narrow neck aneurysm. Now tell me, what are you going to do for a wide neck aneurysm? Should we go and do clipping or coiling for a wide neck aneurysm? मला माहिती नाही. हेड रे मगा fast. Please remember, for a wide neck aneurysm, we do clipping. Narrow neck, you do coiling. For a wide neck, if you do coiling, in case you do coiling, coil will come next day out. Then you will go and do angiography to find where has the coil gone. Okay, so be careful. Now comes the Hira Thakur. It is hair wali kheer. 28-year-old male sustains a penetrating knife injury to the back. Patient is having flaccid paraplegia irreflexia at the level of L1. Ipsilateral spastic weakness and loss of vibration below L1. Contralateral loss of pain and temperature at the L3 dermatome. Preserve bowel and bladder function. What is the precise location of the spinal cord lesion? If the weakness and the sensory loss. Tell me. What is the correct answer for this question? First of all, we should relate where is the lesion exactly. L1, sir. Even in the question, there is nothing of right and left being given. Still, my common sense tells me the right hemisection at L1 is going to create this trouble, not the complete transaction at L1. Because in case we have a lesion on the right side on the L1, at the level of the lesion, posterior column, below the level of lesion, posterior column is affected on the same side. Yes. At the level of the lesion LMN, below the level of lesion UMN on the same side. And the spinothalamic below L1, that is at L3, 2 levels below, it will be involved on the opposite side. Okay. So that's an easy, simple, straightforward question, Brown-Séquard syndrome. So let's go fatafat now. 32-year-old woman with fluctuating dysphagia and normal reflexes and pupil size. Repetitive nerve stimulation is showing you decremental response. Which of the following is the likely site affected in the patient? It's a post-synaptic acetylcholine receptor present on the muscle. This is a classical description of what we know as myasthenia gravis. Look at the story. Ptosis is fluctuating, more in the evening, less in the day. As the day progresses, the ptosis keeps on increasing. Pupillary size is normal. Yes, this is something that you should know now. Third nerve palsy with pupillary sparing occurs here also because it's at the neuromuscular junction. So I'll just jump on to high yield points. Rest I know you know a lot of things. I'll just go through them quickly. It's a postsynaptic acetylcholine receptor problem. Acetylcholine receptor antibody are positive in most of them. Anti-musk antibodies are seen positive in patients with bulbar involvement. Thymic hyperplasia is more common, 65%. 10% of the patient could have even a thymoma with them. Clinical features you know already. The weakness will worsen with activity. Okay. Ocular symptoms are generally seen to be initial symptom. Proximal muscle weakness happens. Sensation and reflexes are present or preserved. Okay, myasthenic crisis. Life-threatening respiratory muscle weakness in a myasthenic patient is known as myasthenic crisis. ISPEC test is a screening test that we have now, where the ptosis improves on exposure to cold. Hydrophonium is the thing of the past, but most sensitive test is single fiber EMG. Right. Treatment, pyridostigmine, you already know. Immunosuppression like azathioprine, mycophenolate or prednisolone. But in cases of crisis, you give the patient plasmapheresis or immunoglobulin therapy and of course ventilatory support. Thymectomy is indicated in all patients of thymoma and in patients with generalized myasthenia gravis whose age is below 55 years. Even without thymoma, yes, 65% are hyperplastic, you have to remove them also. This has also come in the exam. What are the drugs that may worsen myasthenia? Antibiotics like aminoglycoside, fluoroquinolones. Beta blockers, magnesium, and neuromuscular blockers. So the most common antibody is this acetylcholine receptor antibody. That's why we mark the test as most specific test to diagnose myasthenia. Initial symptoms are diplopia and ptosis. Tensilon test will bring in your rapid involvement, but nowadays we are not considering it. With crisis, you give IVIG and plasmapheresis. Now, thymectomy is both diagnostic and therapeutic. Yes, therapeutic in the sense what? You remove thymus, the factory of antibody is gone. And still in dilemma, some of the authors have told that you remove thymus and the improvement will happen. Then you will be very sure, yeah, it's myasthenia. Because antibody titer keeps on decreasing with time. Sometimes it's not very clear. Okay. See, below 15 years, myasthenia is extremely rare. So the bracket is 15 to 55. That's agreed. But the upper side you need to remember should be below 55. Okay. And reflexes and sensation are normal in myasthenic patients. Okay. So let's go to endocrine. 5 questions, quick questions there. 40-year-old male is diagnosed with acromegaly due to growth hormone secreting pituitary macroadenoma. MRI shows me a large mass of suprasellar extension. What is the most appropriate initial treatment? Should I give cabergoline octreotide or remove the tumor? Of course, sir, I'm going to remove the tumor. Acromegaly is something not good. It's going to kill the patient. So removing the tumor, the transsphenoidal resection is the ideal approach. So what is the most common cause of acromegaly? It's pituitary adenoma. Other causes of ectopic growth hormone production is a pancreatic tumor. Growth hormone releasing hormone production is a bronchial carcinoid like a lung tumor. Please remember the clinical features, simple clinical features. Coarse facial features are seen in the patient. With enlarged jaw, that is prognathism. Enlarged hand and feet, which is going to change the ring and the shoe size of the patient. And increase interdental spacing, that is known as what? Jaw malocclusion. They're going to find more space in between the lower incisors. And yes, the hollow voice quality that you find, macroglossia. Thin skin and oily face is also one of the feature. The visual field effects are seen because optic chiasma is getting compressed. Bitemporal amyopia. Carpal tunnel syndrome is seen. Hypertension occurs. Diabetes happens. Obstructive sleep apnea. Although the colonic polyps are benign, but we need to screen them every often because you never know, they can turn themselves malignant. Okay. What are the tests? Initial test is IGF-1 level. Confirmatory test is a growth hormone or a oral glucose growth hormone suppression test. Okay, where the growth hormone fails to suppress at a value which is below 1. Now this is important. Please remember, growth hormone is found to be inversely proportional to glucose. The growth hormone is inversely proportional to glucose, right? Just give me a second. I'll be back. Growth hormone is inversely proportional to glucose, just like you. Tension is inversely proportional to number of days left for exam. Yes. More days, less tension. Less days, more tension. Tomorrow I'll start studying. Remains constant. Okay. So Nadeba, come tomorrow. Aliba, sorry. Aliba, come tomorrow. Oh, topic kal aana. But suddenly it comes in the exam and catches you like a S3. Don't go with that. No, suddenly someone will start putting a case in the court and you will have a belief, "Arey yaar, is saal bhi postpone hoga." Tension is less, but the exam might happen on time this time. You never know. Okay. Treatment. Treatment is transsphenoidal dissection. Treatment of choice. Treatment of choice for patients with acromegaly is always transsphenoidal dissection. If the surgery fails or incomplete, then we add somatostatin analog, octreotide lanreotide, or maybe a growth hormone receptor antagonist like pegvisomant. In mild cases, you can give your patient cabergoline therapy also. Radiotherapy. For a residual or a recurrent tumor, you can advise for radiotherapy. So radiotherapy will come quite later on in the picture. Okay, for residual and recurrent tumor only. So high yield points, what are the high yield points? Most common cause for this is a pituitary adenoma. Please remember. Screening test is not oral GTT. It is growth hormone suppression test. IGF-1 level is a screening test. Prolactinoma में the first line is medical. Okay. यहाँ पे the first line is surgical. Somatostatin analog in cases of unresectable cases or patients who have not received maybe reached their remission. Okay. Excessive growth hormone in children, gigantism in adults is known as acromegaly. Please do regular colonoscopy to rule out colon cancer. And the commonest cause of death that we find in them is cardiovascular complications. Right. A 56-year-old alcoholic male patient with chronic liver disease presents with altered mental status. His sodium is 108. Serum osmolality that you found in the patient is 260. Okay. Urine sodium is 18. Is diagnosed with chronic hyponatremia and started on a cautious correction with 3% hypertonic saline. Yes. After 6 hours, sodium rises to 120 or mar gaye. What is the next appropriate treatment? Tell me. Common sense. If you overcorrect the sodium bill above 10 in a day even, you will end up with osmotic demyelination syndrome. Correct? So please prevent it by giving desmopressin. If you give desmopressin, it will bring in water, dilute the plasma, decrease the sodium. And free water, IV fluid, free water. Let him get only water to prevent overcorrection. Got it? Right. Serum sodium Less than 135 is hyponatremia. You know this? It is considered to be severe if it is below 120. If it is a hypovolemic hyponatremia, what are the causes for this? Number one is GI loss. Second is renal loss with diuretic, even Addison disease, and skin loss through burns and sweating. The most common cause of euvolemic hyponatremia, we've discussed this in the class, is SIDH. Apart from this, to some extent adrenal insufficiency, but it is more often hypovolemic. Hypothyroidism also. And don't forget psychogenic polydipsia. When you drink more water, you retain more water, your sodium goes down, but the volume of your body doesn't increase, you don't have edema. Hypervolemic hyponatremia. This happens in CHF, cirrhosis, and nephrotic syndrome typically, and patients with CKD. Right. So please remember, if the sodium is low mildly between 130 to 134, often asymptomatic patients. When it switches between 125 to 129, although some authors say below 125 to 120 also, chalega. But nausea and headache happens there with confusion. If it is below 120 and a rapid drop occurs, then seizure and coma can occur. Even in the patient, will have severe increased risk of cerebral edema seen in the patient. Okay, so what I'm going to look for? One is the urine serum osmolarity. If it is below 275, it is hyposmolar. If it is 195, it is high, it is hyperosmolar. And what are the causes for hyperosmolar hyponatremia? Increase in serum osmolarity, bring in more water and decreasing the sodium. Hyperglycemia. What is isotonic? Sometime in patients with hyperlipidemia and high protein content, when the tonicity is okay, but there is slightly more water there, okay, and that causes hyponatremia. It is often referred as pseudo hyponatremia. Urinary sodium and osmolarity has to be checked. Serum glucose has to be checked. Management protocol are clear. If it is acute, it is considered to be less than 48 hours. Chronic, more than 48 hours. If it is severe, symptom, treat aggressively. If it is mild or no symptom, always a slow correction. In a patient with acute symptomatic hyponatremia, what are we going to give? 3% hypertonic saline. And the rise has to be 4 to 6 milliequivalent per liter in the first 6 hours, not very fast, slowly. Maximum rise should not exceed more than 10. Please remember, maximum rise should be less than 10 in 24 hours and less than 18 in 48 hours. And don't forget this Medius formula. Okay, I've discussed this in the PYQ section. Right. So if a patient comes to you with SIDH and hyponatremia, what are the treatment that you give? You give Aptans and fluid restriction. If it is hypotonic, hyponatremia, hypovolemic, then you give your patient normal saline, isotonic. In case you have hypervolemia and then hyponatremia, then what? You give your patient fluid and salt restriction, and to decrease edema, you give your patient what? Loop diuretics. Don't forget, most common cause of euvolemic hyponatremia is SIDH. Rapid correction of hyponatremia will cause central pontine myelinosis. Maximum safe correction is 10 milliequivalent per liter in 24 hours. What diuretics are going to cause hyponatremia more often? Thiazide, not the loop. And SIDH. Don't forget, urinary sodium excretion is more than 40 for them. Okay. Just hold on for a second. I'll be back. Just hold on. Okay, my apologies. Sorry. My wife just called me कि वहां से लाके वो दे दो. I was just going for that. Took time. Right. Chalo. 42-year-old male patient presents with chronic fatigue, salt craving, postural dizziness, progressive skin darkening over knuckles and oral mucosa. Diagnosis reveals you this. Sodium is 124, low. Potassium on the higher side. Plasma cortisol is low, ACTH is high. Bolo kya hai? What is the most accurate interpretation of this? Is it a secondary adrenal insufficiency or is it a primary adrenal insufficiency? It's a clear-cut case of primary adrenal insufficiency. Why? Because your ACTH is high, rebound high. Got it? And most important, your cortisol rises on ACTH stimulation. No, it doesn't rise that much. From 4 to 6 it went. It is still low. That means your patient's adrenal gland is not working properly. Primary. Don't forget, primary adrenal insufficiency is an adrenal gland failure. Secondary adrenal insufficiency is a pituitary gland failure. And tertiary adrenal insufficiency is a CRH deficiency due to long-term steroid use. I've discussed this in INI-CT PYQ. Okay. The causes for this primary adrenal insufficiency is autoimmune. Tuberculosis in Harrison still written. We have to obey the Bible. Tuberculosis, developing country. As per them, India is a developing country. But mitro, wait for some time. Yes. Secondary adrenal insufficiency, what? Pituitary tumors. Chronic adrenal insufficiency. Yes, tertiary is chronic steroid therapy. Secondary adrenal insufficiency is due to Sheehan syndrome, trauma, irradiation, or even pituitary tumor where the corticotrophic cells stop functioning. Tertiary is due to chronic steroid therapy. Okay. So quick recap of secondary, tertiary versus primary. Fatigue, weight loss occurs in both of them. Hyperpigmentation occurs in primary. Hypotension, hyponatremia, hyperkalemia, all the problem due to poor aldosterone happens here. Hypotension may be mild in secondary. Why? Because aldosterone level, I've taught this, even Dr. Rahul has taught this in the class many times. In secondary wala, the aldosterone is normal. Hyponatremia is still there. Hyperkalemia is not there. Hypoglycemia, failure of cortisol will be there. When the sodium is normal, low, then you have salt craving. Here the sodium is normal, salt craving is not there. Okay. Simple part of treatment, don't forget. One thing I want to discuss at this moment is adrenal crisis. Please remember, this is a life-threatening emergency which is triggered by the infection, surgery and steroid withdrawal very often. Symptoms of everything will be there where the adrenal gland is malfunctioning. And what are you going to give? Hydrocort with fluid to the patient. Back to this high yield points. Hyperpigmentation, hyperkalemia is primary adrenal insufficiency. ACT is high level in primary, low in secondary. Fluodocortisone is required in primary because they have aldosterone deficiency. They need a mineralocorticoid replacement. Sanactin test is a diagnostic test to differ out primary also secondary as well. So if you give ACTH and the cortisol rises, the problem is in the pituitary. It doesn't rise, the problem is in the adrenal gland. For adrenal gland, adrenal crisis, what do you give? IV hydrocort with saline and glucose. Glucose is something which will come when their blood glucose is low and persistently low. Most common cause of this trouble in India is TB because India is a developing disease. In the West, I hope you know, the West means the Americans is autoimmune. But after launching BrahMos, our missile, we have launched Tharoor to US, and he has just gone and he's speaking so well. Yeah, proud of Mr. Tharoor, Minister of External Affairs. Okay, not external affairs, but good in English. Earlier, Modi ji used to sit with Trump bhai, and they used to be interpreted in between. When Trump is this time sitting with Tharoor Saab, there is an interpreter still for English. Because Trump ka English is desi like us, but Tharoor Saab, the Shakespeare from our country. What of him? Right. 65-year-old male patient with 40 pack year smoking history with fatigue and nausea and recurrent stones has come with a calcium which is 14.5. PTH is suppressed. PTH RP is elevated. Now this is important. Vitamin D is normal and the other part of vitamin D is also normal. What is this? This question almost came in NEET PG 3 years back. I saw this. It has to be a malignancy. Is it a primary hyperparathyroidism or malignancy related? It's a humoral hypercalcemia of malignancy, possibly a lung cancer. Yeah, Sanactin, co-syntropin, ACTH stimulation test, all three mean the same. So if the calcium is above 10.5, you call this as hypercalcemia, and severe form comes when it is above 40. Okay, and don't forget this corrected calcium value. They keep on asking about this also. Mnemonics to remember this we have already done in the classroom teaching chimpanzee and all. Clinical features also we have done. Okay, and treatment approach also. Okay, you can go back and see the notes again. Normal saline, please remember, is the first step. Loop diuretic to cause calciuresis is the next step. Bisphosphonate are the third step. Temporary effect can be given by calcitonin because of the rapid onset of action. And steroids are going to inhibit the active form formation of vitamin D. So it is quite helpful in patients with vitamin D excess and sarcoidosis, especially granulomatous disorder. Dialysis will come when there is renal failure and a severe hypercalcemia seen in the patient. Okay. Now going and jumping to the high yield points. Hypercalcemia, what is the earliest sign? Short QT interval on ECG. Most common cause. Hospitalized patient is malignancy. Yes. Yes. This we have seen, hypercalcemia, malignancy matches a lot in hospitalized patient. Primary hypoparathyroidism, non-hospitalized patient. Ambulatory. Yes. PTH level is key in the diagnosis. First step in emergency to treat hypercalcemia is IV fluid. Bisphosphonates are the mainstay in therapy for malignancy related causes. And please remember, hypercalcemia for sarcoidosis, what do you give them? Steroids. At least remember these high yield points. Last ball of the match. I think so Dr. Bharat must be waiting. Sorry Garu. For a time lagega. 25-year-old woman with type 1 diabetes presented with vomiting, a small respiration confusion. The glucose is 510, pH is 7.05, bicarb is this. You started the patient on IV fluid infusion. After 2 hours, serum potassium drops to 3.2. What is the most appropriate next step in the patient? Continue insulin at the same rate and monitor potassium. Stop insulin immediately, administer dextrose. Administer soda bicarb to correct acidosis. Rule out everyone. Apply your common sense, yaar. Continue insulin, give potassium supplement. Yes. Ideally, I could have stopped the insulin, but I know when I give potassium, things are going to recover. Scenario is different. Man lo, the question comes with this format and you have not started anything. Now the scenario becomes slightly different. The patient has come with these parameters, that is 3.2 potassium. Okay, initially only there is 3.2 potassium. Please don't give insulin, give potassium first. Okay. So DK, you know, yes, the definition, the pH and ketosis. And don't forget my 5 idiots which come very often. What is infection? Yes, I used to tell 3 idiots, now there are total 5 now. Infection, most common cause. Insulin omission, non-compliance. Not infection, this insulin infusion. ischemia and infarction, intoxication, and intercurrent illness like pancreatitis and surgery, where the insulin demand increases actually. Clinical features we already know, and yeah, the anion gap increases in them. There's something discussed in EBG also. Management protocol, airway, breathing, circulation. ABC assessment, oxygen if needed, bolus IV fluid. How much bolus? 0.9%. Fatafat. Change it to dextrose when the glucose goes below 200. Some authors say 250 chalega. But that's the threshold that we keep between 200 to 250 if it is there. We switch to 5% dextrose to prevent hypoglycemia. Now most important, give insulin. Giving bolus insulin is optional. Now this is optional. Someone told me, sir, Harrison mein kahan hai? So I again say this is optional. Giving bolus insulin. Why? See, if the patient is having a normal potassium, you give bolus insulin, what will happen? The potassium will fall. So again I say it is optional. Optional giving bolus insulin. Then continue infusion of insulin at 0.1 unit per kg per hour. And don't forget, don't reduce the glucose beyond this level. Itne se hi karna hai, 50 to 75. Right? Potassium below 3.53. Yes, replace potassium before insulin. 3.3 to 5.3, give potassium along with insulin. More than 5.3, monitor and no potassium initially. Complications, especially in children, is cerebral edema, hypoglycemia, hypokalemia. Okay. Criteria for resolution of decay. This has come long back. When the glucose level is below 200 or any two of them, pH more than 7.3, bicarb more than 15, and anion gap has normalized. Because if there are keto acids, to neutralize the keto acid, you use bicarb and the anion gap increases. So, high yield content, decay more common in type 1 and hyperosmolar state in type 2. Beta hydroxybutyrate is the most abundant ketone. This has come in biochem. First step is always IV fluid, not insulin. Potassium correction is critical before giving insulin. Dextrose is added once the glucose value shows below 200. 250 bhi chalega, it's fine. So in the range of 200 to 250, you add dextrose. Most important, acidosis correction if the pH is below 6.9. I always teach 7, but in Harrison now it is 6.9. That's also fine. Some decimal change is there. And always search for infection as a precipitating cause. So finally, any doubts, any queries from your end? Let me know. Any doubts, any queries? You'll get the PDF. You'll get the PDF, don't worry. Right? Just give me a second. I hope I'm through the session now, and any doubts and queries, try to sort it out. And अपना time आएगा नहीं, अपना time अपन खुद लाएगा. Now this is the name that speaks louder than words. अपना time अपन खुद लाएगा is most important thing. Okay, so you will have the exam in 2 sessions. 1 session, don't think about it. Exam hona chahiye should be your priority. Tension is inversely proportional to number of days left for exam. Kal padhenge is a constant. Remove the constant, go back and revise. What you have read is good. Please revise it so that in the exam you can easily recall everything, no regret over there. In pituitary question, sir, if it is asked, see, In prolactinoma, the first treatment is medical. Acromegaly, the first treatment is surgical. That's you should remember. Okay, thank you very much. Right.
I'll use this. Okay. Good evening, students. I hope after a rocking session by Archin sir,